67-year-old with a history of hypertension, end-stage renal disease on hemodialysis. Typically has got hepatitis C positivity, and he is having typical lesions. What kind of lesions are these? Blistering lesions. And the urine is typically showing a port wine stain. So what is your diagnosis? Which porphyria? You should always suspect possibility of Porphyria cutaneous tarda, which typically lead to skin lesions, cutanea tarda, along with port wine stain. But how is it different from that of other types of porphyria? Other types of porphyria, you have neuropsychiatric manifestations. But in this, there will be no neurological manifestations, only cutaneous hypersensitivity will be there, and hepatocellular carcinoma predisposition will be there, and the treatment is by doing phlebotomy, where you puncture their vein and squeeze out a couple of units of blood on a regular basis is considered to be the treatment of choice. Now doctor, the liver histopathology has been shown to you. So what are the drugs that need to be avoided in this patient? Fundamentally, what is this histopathology making you to think of? Very simple. Cirrhosis of liver. Are you not able to see the fibrosis? You remember our histology days, hexagonal shaped liver is a normal histology. It's a trichrome strain where you have the fibrosis. There are a lot of sad faces. Why? Today's test image based questions are not that straightforward. Or are they not clear? The images are not clear. From next week we will, this week only we would have done it. From next week actually what we will do is we will try to put all images in a blog which you can open on your smartphone. I mean offline students. For online students it should be clear. So yeah. So in histology, indapamide, diazepam, aspirin, all these are generally avoided, but not the paracetamol. It can still be given in a dose of less than 2 grams per day in cirrhotic patients, is the point of view. A 45-year-old, a middle-aged woman presenting with pruritus with antimitochondrial antibodies. Do you really look at liver biopsy? Even without looking at liver biopsy, only middle-aged pruritus with antimitochondrial antibodies means what is your diagnosis? PBC. Primary biliary cirrhosis is what you need to basically remember. So anyway, histology also shows primary biliary cirrhosis. So how do you treat it? In that the uric acid levels are very high. Bile salt levels. Bile salt levels are very high. So you give ursodeol, cholestyramine, zinc supplementation, but not pegylated interferon. Where will you give pegylated interferon? Typically in case of the hepatitis B. In the last before week, in the Sunday test I told you, hepatitis B, hepatitis C. Clinical management, when to give ribavirin, when to give interferon, what are the complications of interferon therapy, all that which is there in your same sweet Davidson, general medicine, you have to read. Otherwise, we also discussed that and it is there in the online video library at anatomytomedicine.com. You can review them in the general medicine video library. So, but it is very important. Definitely one question will come. Now doctor, a peripheral smear is shown. What are these cells called which are having those thorny projections? Thorn-like projections are there. Acanthocytes. So otherwise, where do you see acanthocytes? Typically, we see it whenever there is a cirrhosis is the classical location where acanthocytes are found. Now you have been shown a histology of the thyroid gland. What is this histology called as? Hurtle cell histology is the name which is being given. Hurtle cell histology portends a poor prognosis in case of follicular carcinoma of the thyroid is what you have to basically remember. So the thyroid follicular cells undergo a metaplastic change and typically that lead to development of Hurtle cell histology. Now there is a histopathology of the liver being shown. So what does this histopathology basically show? Macrovesicular steatohepatitis. There are two types, microvesicular, macrovesicular. A favorite list that you need to remember in pathology, frequently asked in PG medical entrance. You have to write it in your 200 pages wala notebook, this point. So, of the various, and some will cause both microvesicular and macrovesicular. Even that also a headache list you have to keep in your pocket. So, Reiss syndrome does not lead, but alcoholic liver disease, syndrome X, lipodystrophy, macrovesicular steatohepatitis will be found. Now here we show you the presence of an excretory urography. What is this sign called as ring sign in the pelvic ileal system is what you are able to see. So what we are asking you is what is the most likely case history in this given case. So where do you find this kind of ring shadows? Whenever there is a papillary necrosis. What are the three causes of papillary necrosis which you should not forget? Analgesic nephropathy, diabetes mellitus and sickle cell nephropathy. So, and recurrent reflux UTI, any of them can lead to development of papillary necrosis. So, doctor, the most likely possibility is a ankylosing spondylitis guy. In fact, you can appreciate the bamboo spine. All the syndesmophytes have led to the fusion of the vertebrae like a bamboo, and this guy was taking analgesics regularly and he developed a renal papillary necrosis. Come on, within a short period of time you are going to be MD general medicine, MD radiology, big departments. The entire department depends on you. It doesn't depend on HOD. It depends on residents. Good residents make a good tertiary hospital because you are the workforce of the hospital, right? So, elevate yourself to the point where you are ready to face any question of the examiner and clinically incline yourself, because nowadays exams, all India, DNB, JIPMER, PGI, everything, they are all becoming more and more clinically oriented. More number of clinical questions. If you take the last time state PG entrance, there were about 36 images and around 35 case studies. So it is a completely well loaded paper, the best paper ever conducted in the APPG, Andhra Pradesh postgraduate entrance. This time one more best paper will come and you are all our best students. So you need to make it happen. So now doctor, a 75-year-old with azotemia, bone marrow biopsy is being shown. Typically, what features can have an association with this condition? Except, so you are finding prominent plasma cells. What is the cause of the death in multiple myeloma patients, doctor? Renal failure, infection are the two major killers, causes of mortality in case of multiple myeloma is what need to be remembered. So how does multiple myeloma lead to development of renal failure is a very important question. So it leads to eosinophilic interluminal cast, it can lead to interstitial multinucleated giant cells, and in multiple myeloma patients, don't forget, multiple myeloma patients, diabetic nephropathy patients whose creatinine is high, they are all at a great risk of developing contrast induced nephropathy. whenever you are posting them for any interventional procedure where you need to administer the contrast, you have to hydrate them very well. So this is the month of August. By the time it is April, May, we'll have a summer, scorching heat, and you are the postgraduate with perspiration, of course. Nowadays, a lot of hospitals are air conditioned. So, and your patient is being posted for a contrast procedure. First thing, what will you do? You hydrate him very well. You will collect his urea creatinine report. You will check, is he a vulnerable patient for contrast-induced nephropathy? And post-procedure, you will repeat the creatinine until the patient is discharged. All your heart will be heaving to see that he doesn't fall into that contrast-induced nephropathy category, which is not good. And when you are on duty, how can it happen? It should not. So that should be the outlook. So multiple myeloma is one risk factor. 38-year-old female with eosinophiliuria, that itself is sufficient. You don't need to even look at renal biopsy. Only condition that you know which lead to eosinophiliuria is interstitial nephritis, right, which can occur whenever there is a drug-induced situation. So all these red-colored ones which are able to see are all eosinophils. Spots are all eosinophils. A renal interstitium is not supposed to have these many eosinophils. All the spots which you are seeing pointed by these arrows are all eosinophils. So, what is the triad of clinical features which you see in case of interstitial nephritis is my question to all of you. Fever, rash, eosinophilia is what you have to basically understand. A 36-year-old is having history of joint pains and her radiograph has been shown. What do you see here? Z deformity, swan neck deformity, subluxation of the joints. They are all the features of what? Rheumatoid arthritis. So the question is, what is the common glomerular involvement in rheumatoid arthritis? Whenever rheumatoid arthritis patient develops renal involvement, it is the amyloid nephropathy which is commonly seen. When will amyloidosis typically occur? In the background of a chronic inflammatory state. Anything that leads to chronic inflammation. Before the era of the antibiotics, today we are in the American Scud missiles. We have got imipenem, we have got meropenem, so many advanced antibiotics where you can go and hit and behead the E. coli and stop the sepsis. But before the advent of all those antibiotics, chronic osteomyelitis, a lot of people used to have. Osteomyelitis used to go into chronicity. And chronic osteomyelitis is one of the very common cause of amyloidosis in pre-antibiotic era. But the present era, rheumatoid arthritis, which is another chronic inflammatory condition, is the most common cause for the development of amyloidosis is what need to be remembered. A female patient comes from the village, Lachakka Buchava. She told you that, doctor, my mouth is very dry, and you opened her mouth and you found that there is a dental caries. If the dental caries is there in a bubble gum chewing young college girl from Stephens College, Delhi, it is okay, expected. Or if it is found in a very posh looking fashion designing college going girl who eats chocolates regularly, fine. But Lachakka Buchava is not supposed to have, because she takes very nutritious regular food from her own farm. But why there is a drying of the mouth? Because the Lachakka Buchava was having a lymphocytic infiltration into her salivary gland, exocrine gland. There is no salivary secretions coming, hence mouth became dry, and that is a source for infection, hence she developed dental caries. And when her Uncle died, she didn't have tears. To not have tears is okay if you are city born, because in city life is so fast that if somebody died means, oh, it is it, please catch up with me on WhatsApp. At most on WhatsApp you will send a condolence message and say, lol, you gone to heaven. But in village they will definitely have time for having tears, but no tears, because her lacrimal glands, which are also exocrine, there is a lymphocytic destruction. She also has joint pains. So joint pains with exocrine gland insufficiency. On phone only, what is your diagnosis, doctor? Sjögren syndrome is what you have to basically remember. And typically this dry mouth of Sjögren syndrome, dry tongue of a Sjögren syndrome patient, how do you know it is dry? Can you touch it and check that fissuring of the tongue is a very important clue. Then if you do renal biopsy, typically what do you find? You find a lot of tubulointerstitial pathology, which is the classical pathology which you see in case of Sjögren syndrome, is what I want to underscore to all of you. That's right, Vijay rightly said, Sjögren syndrome. Now doctor, liver biopsy of a 34-year-old from Manipur, hepatosplenomegaly is there, and what do you observe in his on his face? Pigmentation, right? Then what is the possibility where hepatosplenomegaly along with iron deposition diffusely into the liver is hemochromatosis. Now what are the complications of hemochromatosis, doctor? Which are reversible versus those which are irreversible. So if you do phlebotomy regularly, what you can be able to do is you can control the degree of diabetes, degree of hepatic fibrosis and cardiac failure, but not arthropathy. Similarly, hypogonadism, which you see in case of hemochromatosis, is also irreversible. One of the favorite questions of examiner क्या होता है? Hypogonadism, why does it occur in hemochromatosis? Is it a hypogonadotropic hypogonadism or a hypergonadotropic hypogonadism? What is the type of hypogonadism do you have? Can you give me the board please? See doctor, testis. Here we have got the pituitary. Pituitary produces LH. LH is responsible for the testosterone production by the testis. If something happens to the testis, can you give me one condition, chromosomal condition where testicular hyalinization is seen? Klinefelter syndrome. When the testis degenerates and it can't produce testosterone, normally testosterone goes and inhibit the production of LH, normally. But if testosterone is not produced, LH का levels क्या हो जाता? High हो जाता. So this kind of scenario where the peripheral apparatus, testis में problem है, and patient has got hypogonadism. Along with that, what will they have if testis is having the problem? What is LH called? Gonadotropin. So he will have hypergonadotropic hypogonadism whenever testis has a problem. Suppose pituitary is degenerated, what will happen? They will have hypogonadotropic, and if pituitary is not producing LH, even testosterone is not produced. Hypogonadism they will be having. So which type of hypogonadism patients of hemochromatosis will have? In hemochromatosis, do you think iron will go and deposit in the testis and iron testis will form? What? It doesn't form. The cause of the hypogonadism in hemochromatosis is iron will go and cause pituitary deposition. and causes a low LH, because of which there is a hypogonadism. Hence, what type of hypogonadism? Hypogonadotropic hypogonadism is what you see in case of the hemochromatosis is what need to be remembered. So, what is the favorite question of the examiner in hemochromatosis? In an untreated case of hemochromatosis, what is the cause of death? If you don't treat hemochromatosis, वो पूरा आयरन जाके कहाँ डिपॉजिट हो जाता? लिवर के अंदर डिपॉजिट हो जाता. इसलिए hepatocellular carcinoma is the most common cause of the death in case of untreated cases of hemochromatosis. अगर आप ट्रीट किए, you have treated them, then a small amount of deposition keep continuing over a long period of time into the heart, and cardiomyopathy will develop, and cardiac failure will develop, and cardiac failure is the most common cause of the death in a treated case of hemochromatosis. You will remember me in exam hall when the examiner asked this question. Very good. Harika rightly answered. Treated cases में होता है CCF, untreated में होता है HCC. Hepatocellular carcinoma is what need to be remembered. Now you have been shown an ECG in a patient. What is a classical thing on ECG? Totally, doctor, 20 to 25 classical ECGs will be there. Hyperkalemia, tall peak T waves, delta wave, WPW syndrome, and after T wave, development of U wave, which you see in hypothermia. Like that, how to recognize VT, how to recognize polymorphic VT, how to recognize second degree heart block. So totally 25 ECGs will be there. We already discussed it and put it on anatomy2medicine.com video library. You can always have a review of the topic ECG, but you should not do mistake. Common ECGs, how to recognize. So what is the problem in this? This is called coving. Cove के जैसे दिखाई दे रहे ना? Coving of ST segment. This is ST segment elevation. This is QRS complex and this is the T wave and this is called ST segment. So ST segment elevate तो हुआ, मगर coving ST like a cove is a feature of Brugada syndrome, which occur because of the sodium channel defect in the myocardial cells, is what you have to basically remember. So a 54-year-old with schizophrenia and bipolar affective disorder, especially if a patient is having Brugada syndrome, generally they don't die simply like that. But presence of Brugada is a risk factor. If the patient takes drugs like tricyclic antidepressants, etc., they will suddenly develop ventricular fibrillation and die. You will be thinking, अरे hundreds of patients I have given tricyclic antidepressants, इसको क्या हो गया? मैंने चिट्ठी लिख के दिया, मेडिकल शॉप वाले दिया और वो घर लिया और क्रिकेट मैच देख रहे, मर गए अब्बा ने. तो पेशेंट सन विल कम, अच्छा हाँ आप वकील साहब का नोटिस कहाँ किस एड्रेस पे भिजाऊं सर आपको? हमारा अब्बा हट्टा करता है, खाली उसको नाराज बहुत होता है इसलिए आपके पास लाए. ही इज शिजोफ्रेनिक, बीच बीच में थप्पड़ मारता है इसलिए लाए हैं. फिर भी उसका दिल अच्छा है डॉक्टर, उसको आपने मार दिया डॉक्टर, आपने प्रिस्क्रिप्शन लिख के. नाउअडेज व्हाट डिड सुप्रीम कोर्ट सेड? डोंट राइट monkeyish way. You have to write in all capital letters clearly, right? So Dianyl is a dangerous prescription that you can write. I cannot forget one of the patient. Dianyl, there is one more brand of multivitamins which also comes with DIA, first 3 letters. So one clinician wrote in monkeyish this thing and patient gave Dianyl, I mean medical shop fellow, and he consumed Dianyl and he developed hypoglycemic coma, and suddenly his son, who is a doctor in London, came for the funeral and seen his father's prescription. What did he take in the last hours? Because don't forget, lot of your patients' sons will be there in London. MBBS खत्म करते ही गुड बाय पापा बोल के वो लंदन चले जाते, डेथ के बाद वो आते हैं. And lot of your patients, younger brothers who die in your hand will be advocates. So you have a good combination, right? If the son is doctor and brother is advocate, khatam, you are perfectly in a soup. So इसलिए family history is important. Why professor keeps telling, have you taken family history? Means this is the family history you need to take. So but the problem is, the consultant wrote in his monkish language DI से शुरू होने वाले multivitamin, but in computer में enter करते हुए resident ने उसको dianyl कर दिया. So that was actually the mistake. So printed discharge summary में dianyl was there. So he paid huge compensation. पूरा जिंदगी में जितना भी कमाए वो देना पड़ा. So that's the reason. And on the top of it, what a unfortunate thing, even for patient's family. That's the reason discharge summary is like a Supreme Court judgment. As a house surgeon, our duty is what? To write discharges. Even as resident, to write discharges. We think it's a very callous and simple job. But that is a diagnosis you are pasting on the head of the patient. If you don't properly write how he is treated and what he is treated for and what is the final diagnosis and what is the discharge prescription, patient is going to end up in a lot of problems, and in the future nobody will know what happened to him in the last in-hospital stay. इसलिए discharges लिखते वक्त आप PG entrance के बारे में भूल जाओ और discharges काम खत्म करके on mobile phone only, our anatomy2medicine.com video library is available. You can always review whichever lecture you want to listen. Okay, so no tension of missing a live class and other things. So this is Brugada syndrome. Okay, doctor. Now, a 47-year-old with antiphospholipid antibody syndrome with abdominal pain. Angiogram has been done to her. And what do you see here? You are seeing a lot of collateral vessels. That means venous system got occluded due to a thrombus. And when you have done the angiogram, what do you see is those fine vessels like a spider web. Okay, so what is this condition? It is called Budd-Chiari syndrome. Now let me talk about Budd-Chiari syndrome. Can you give me the board? See, you have a gut, small intestine. From small intestine, blood will go to the liver. What is this called? Portal vein. And all become small hepatic sinusoids. From here, what will arise? Hepatic vein. Where will it drain into? It will drain into IVC. IVC will go into where? Ultimately into right atrium, right? So this is the direction. Any hepatic vein thrombosis, if it is there, then the venous drainage leaving the liver, how will it go to IVC? It cannot go. But God has given one small secret exit for the blood from the liver. What is that? All other lobes of the liver drain into hepatic vein. Caudate lobe of the liver is directly connected to the IVC. इसलिए whenever Budd-Chiari syndrome is there, where hepatic vein thrombosis is there, all the blood through the caudate lobe will go into IVC. That is the reason what will happen, patient will show selective hypertrophy of the caudate lobe, which is a characteristic feature. Okay, in one of the questions in kynoid classification of liver segments, I will show you where is the caudate lobe, but selective caudate lobe hypertrophy. But what is happening? Lot of collaterals are basically forming here when caudate lobe is draining, because all other segments have to form collaterals and drain into caudate lobe and enter remaining part of liver. So that is the reason all those collaterals will form a spider web if you pass contrast agent into venous system. So that is the typical spider web appearance. If you happen to do in the liver, the contrast will lead to spider web appearance is what you need to remember. So 2 words. Abdominal pain in any patient who has a prothrombotic tendency. Caudate lobe hypertrophy. Spider web appearance on hepatic angiography. 3 buzzwords which you need to ultimately remember. So what will Budd-Chiari will lead to? Tender hepatomegaly, intractable ascites and right upper quadrant pain. These are all the classical features is what need to be remembered. A 32-year-old woman from Kolkata comes with hemochromatosis, and what is her chest x-ray showing, doctor? Harika and Saurabh are saying video struck. Can you restart it so that is it clear there here? Right. Yeah. So what do you see here? A cavitating lesion in the lung, and when you have done the biopsy, palisading granuloma with epithelioid cells is what you are able to see. So it is a case of Wegener's granulomatosis. What does Wegener's granulomatosis lead to? It leads to 3 things. Granulomatous vasculitis leading to necrosis of the upper respiratory tract. Patients will develop sinusitis. They will go to 4 to 5 ENT surgeons. Everybody will take one nice CT scan and advise them for some sort of a repair, but patient doesn't have guts for that, and he don't need also, because the underlying diagnosis is not deviated nasal septum, right? There is a necrosis of the cartilage of the upper respiratory tract because of the necrotizing granulomatosis. Patient will have what? A cavitating nodule in the lung, lower respiratory tract, leading to hemochromatosis. Patient will also have glomerulonephritis involving the kidney,